before I get started, I just want to ask you all to go ahead and raise your hand if you've ever worked with a patient who was overweight or obese and you thought they might benefit from losing some weight and found the process of working with them to be a bit frustrating. Okay, so my hope for this talk today is that you'll leave and you'll feel like you know how to have more effective conversations with patients about their weight. So I want to start by just letting you know my take-home points of this talk today. So if you leave here and you've got these 2 points, then I've done my job well. The first is that weight stigma is a really important factor for us to understand in healthcare, and it's going to be influencing your interactions with these patients who are coming in and are overweight or obese. So we really want to understand it to the best of our ability. And the second is that we want to shift our focus from talking to patients about the number on the scale or their BMI, and really focus instead on health behaviors, things like eating nutritious foods, getting a good amount of exercise. And I'm going to be talking today about why that's important. I want to step back a little bit and talk about why we view weight as a problem. And we really view it as a problem. So you can see from these magazine covers that people are really freaked out about weight and obesity. And this is true not only in the public and in our culture, but certainly within the academic literature as well. And there's a reason for that. We can see from here that people who are obese or overweight have a much higher risk level for a whole host of negative health outcomes. So this is the relative risk of getting these disorders or diseases relative to people who are normal weight. And so people who are obese are at much higher risk for things like type 2 diabetes, obstructive sleep apnea, and even some things like cancer. So I honestly believe that we want the best for our patients, for ourselves, and for our patients. And so it makes sense that when they come to us and they have these health problems or they're at risk for these health problems, what we recommend is weight loss, that will reduce their risk for these negative health outcomes. And how do we recommend doing that? Our general formula, both inside academia and out, is you should eat less and exercise more, which sounds very simple, and I think we want to be helpful, and so we're kind of providing this simple formula for patients. And we also get this message from the media. So we see here, we're obese because we're eating more junk and we're getting less exercise. And what's the solution? Well, you better get on a diet. That's how you solve this problem. Unfortunately, these kinds of messages result in a very weight stigmatizing environment. So what is weight stigma? Weight stigma is the belief that people in larger bodies are lazy, unsuccessful, unmotivated, less intelligent, slow, unhealthy, unattractive. And these ideas are often perpetuated by the idea that, if they really wanted to lose weight, they could. They just need to eat a little less and exercise more. And that really propagates these stereotypes about people in larger bodies. Unfortunately, there's a lot of consequences of these stigmatizing viewpoints or stereotypes. So first of all, we know that people who are overweight or obese are less likely to get hired or promoted in their jobs. They're making less money doing the same work as people in normal weight bodies. So there's some clear discrimination happening. In addition, there's healthcare disparities, which I'll touch more on in a little bit. And this can lead people who are overweight or obese to really avoid seeking healthcare for fear of being stigmatized. Anytime that somebody experiences stigma or discrimination, that causes stress. And so we know that people who experience stigma have increased levels of cortisol, and they often respond to weight stigma by actually eating more and avoiding exercise, which ultimately can lead to more weight gain. So this is kind of a maybe oversimplified visual picture of how weight stigma can actually keep people in this cycle of gaining more weight. They experience some stigma, which can lead to stress, increased eating, having more cortisol, further weight gain, which sets them up to be re-stigmatized, and this cycle just continues. Here are some examples from real people about experiences of weight stigma that they have had. My mother telling me in a loud voice at a family gathering that I should buy my clothes at the tent and awning supply store. And we know that the most common arena that people experience weight stigma is from their friends and family. But the second most common setting where they experience weight stigma is healthcare. I think the worst was my family doctor, who made a habit of shrugging off my health concerns. The last time I went to him with a problem, he said, "You just need to learn to push yourself away from the table." It later turned out that not only was I going through menopause, but my thyroid was barely working. And weight stigma doesn't only impact people who are in larger bodies. My doctor wouldn't believe that my symptoms were serious. He said, "You're too thin and fit to have diabetes." So let's explore a little bit more how weight stigma can show up in healthcare. As providers, we are less likely to provide patient-centered care for patients who are obese or overweight. And that can look like communicating in a less patient-centered way, showing less positive affect during a visit, not giving as much information, and this can come from the belief that, well, clearly they're not going to do much about their health anyway, and sometimes over-attributing patients' problems to their weight. On the patient side, this might lead to feeling shame in medical settings, to almost being on the lookout for rejection, expecting that people are going to judge them. My doctor is going to tell me to lose weight again. Expecting poor treatment based on past experiences or just based on our culture and the way that we view weight. And people might even end up avoiding or delaying seeking health care for these reasons. And I want to highlight that this actually is not only affecting patients. We know that providers who are overweight are also being stigmatized by their peers and by their patients. Their patients might be less likely to take their advice seriously if their doctor is overweight. So if we look at this obesity epidemic, there's kind of this big assumption that's in the middle of it all, that significant long-term weight loss is both medically beneficial and a practical goal for patients. But instead, what I'm going to argue today is that weight itself does not actually have as big of an impact on health as we're led to believe. And I want to be very careful here to distinguish that throughout this talk, I'm differentiating between weight, the number on the scale, and behaviors, things like eating nutritious foods, getting a good amount of exercise, all those types of behaviors. And I'm also going to argue that telling a patient to lose weight can actually cause more harm than good. So let's start by looking at the medical benefits of weight loss. Let's dive into the research and see, is this a myth, is this a fact, is this a little bit of both? And there's been some really good research out there on this idea of, is it fitness or is it fatness that really determines somebody's longevity, mortality, and health in general. And the current paradigm is very focused on weight as a risk factor, as we saw earlier, and weight loss as the primary strategy to reduce that risk. But what we see in the research, and I'll go more into this in a second, is that actually having a moderate to high level of cardiorespiratory fitness reduces or completely eliminates the mortality risk associated with being at a higher BMI. And when we look at the effects of weight loss, it doesn't necessarily result in sustained improvements in cardiometabolic health, even if the weight loss is sustained, which makes us question, is it really the weight loss that's going to be helpful or something else? So let me show you some examples of this type of research that I'm talking about. This was a meta-analysis of 10 longitudinal studies that were looking at mortality. And so here we have, from those 10 studies, over almost 93,000 patients. And they divided the patients into categories. So you see across the bottom here, we've got normal weight, overweight, and obese. And then within each of those weight categories, they divided people into those who were cardiorespiratory, had fitness in terms of their cardiorespiratory fitness, or not fit, so fit versus unfit. And on the left, we have their hazard ratio for mortality. So if you just focus on these three fit categories, or bars, you can see that there's really very little difference in mortality risk if you're just looking at those who have cardiorespiratory fitness. And I really want to highlight that even obese people can have cardiorespiratory fitness, and that again, their mortality risk is going to be pretty similar to somebody who's normal weight and has cardiorespiratory fitness. And similarly, if you look at these unfit people, something really important to highlight here is look at the mortality risk for normal weight people who are unfit. And this is where our weight stigma might be impacting people who are actually normal weight because we're not assessing for their fitness levels, potentially. There was another study that looked beyond just cardiorespiratory fitness. Let's look at other health behaviors. So this was a nationally representative sample of about 40,000 patients, US civilians. And they wanted to look at whether people were consuming 5 or more fruits and vegetables a day, exercising more than 12 times a month, were they having low to moderate alcohol consumption, and were they smokers or not. And what this study found, again, is that they had the same risk for all-cause mortality if they had all 4 of those health behaviors, regardless of their weight category. And we can see that visually here. So again, across the bottom, we have people who have either none of these healthy habits, 1 of the healthy habits, 2, 3, or all 4 of these healthy habits. And on the left, we have the hazard ratio for mortality. And then the different shades of the bars are different BMI categories. So if we look at this category here, people who had all 4 of these healthy habits, there's really no difference in their mortality risk as long as they, based on their BMI category, as long as they had all 4 of these habits. So that was kind of looking at all-cause mortality, but I also want to take a minute to dive into more specific diseases and disorders. In general, we know that people who make lifestyle modifications with or without weight loss, that's going to have a really good effect on their prognosis, right? It might prevent disease onset, mitigate disease progression, and sometimes even reverse existing disease. And we have really good research showing us that this is true even if the person doesn't lose weight. And then I'm going to take an even deeper dive into a very specific problem, one that we commonly recommend a solution of weight loss, so osteoarthritic knee pain. One example comes from the Arthritis Diet and Activity Promotion Trial, which was with 316 overweight and obese adults who had osteoarthritic knee pain. And they were randomized to one of 4 different conditions in this study. So one condition was they were just put on a diet, and the diet was really for weight loss. So it was restricting calories and changing nutrition with the goal of weight loss. Or they were put in a group where all they had to do was exercise. There wasn't really an emphasis on weight loss. There was a combined group of diet and exercise, and then they had a control group, which was kind of treatment as usual. And so what they found is that the diet and exercise group had the best outcomes. But the authors really highlighted that without the addition of exercise, dietary weight loss alone does not result in significant improvements in mobility or self-reported function and pain. It was really the combination of these things that was the most helpful. And another thing that I like to highlight here is that sometimes there's this assumption that weight loss would decrease the load on the joint, and so that's why I'm telling my patient to lose weight, because that's going to be helpful for them. It's going to reduce the pain. But just something to kind of challenge that mindset is that we know that the patients who were in the exercise-only condition significantly increased their walking velocity. So they were walking much faster, and that actually placed an increased load on their knees, and yet their pain decreased. So sometimes it's just a matter of taking a step back and challenging some of these assumptions we have based on weight. I also do want to highlight here, though, I'm not saying that weight loss isn't helpful at all. We see that the diet and exercise group had the best outcomes. It's just that sometimes we place so much emphasis on weight loss and we don't pay as much attention to other factors. Another study, same problem, same issue, but another study looked at the longitudinally the progression of osteoarthritic knee pain. And so they worked with 228 veterans and community participants who had knee pain, and they followed them over 30 months to see whose knee pain progressed. And what they found is that the risk of progression was really based on the alignment of the knee. So for patients who had a neutral alignment of their knee or severe malalignment, it actually really didn't matter what their BMI was or their weight loss on the progression of this problem. It was only for the participants who had kind of moderate malalignment where their weight was impacting. So again, this is just an example where we might be recommending weight loss for patients with neutral or severe malalignment when it's really actually not going to be that helpful for them. And again, we do see, when somebody has bariatric surgery, they are reporting improvements in pain and improved functioning. So again, I'm not saying that weight is not a factor at all here, just that it's often overemphasized. Let's take another issue where we often prescribe weight loss, obstructive sleep apnea. So there was a cool study that looked at, is it going to be most helpful for patients to use a CPAP to lose weight or both? So they looked at 146 veterans and civilians who were fairly obese and randomized them to either just doing the CPAP, just doing a weight loss program, or a combined program, and they followed them over 24 weeks. And what they found is that the serum C-reactive protein was significantly reduced in weight loss monotherapy, but not CPAP. And when they combined the two, it was still not more effective than just weight loss. So based on this study, we'd say, okay, great, like weight loss is going to be really important for these patients who have sleep apnea. However, this is a really great example of a study that is flawed, and let me tell you why. They didn't look at the impact of exercise in the weight loss group. So as part of this weight loss program that they were doing, the participants built up to 4 50-minute weekly exercise sessions by week 15 out of the 24 weeks. So they were doing a fair amount of exercise. And we know that when people with sleep apnea start exercising, it reduces their resting CRP levels by multiple mechanisms. And a meta-analysis that looked at this highlighted this fact. Our meta-analysis demonstrates that exercise training leads to a significant reduction in apnea-hypopnea index, improvement in sleep efficiency and daytime sleepiness, independent of the effects on BMI. So although the effect size in AHI reduction seems smaller compared with CPAP and oral appliances, exercise training may be an ideal adjunct therapy, especially considering its effects on sleep efficiency and daytime sleepiness. So I highlight this to say it really matters when researchers are not looking at the unique contribution of exercise or nutrition in their studies on weight loss, because that really dictates the recommendations we're going to provide for our patients. So just to kind of summarize that, the research on the impact of weight loss is really incomplete because many research studies equate weight loss with healthy behaviors, and a lot of them confuse correlation with causation, which is one of our most basic research mistakes, right? But so many studies out there say, well, the fatter you are, the more likely you are to have this disease. That's a correlation, but a lot of people take that and assume causation. I'm going to pause for water real quick. Okay. So we've learned so far that sometimes we overemphasize weight with our patients and weight loss. But even if you do have a patient who you think would really benefit from losing some weight, how feasible is that? What is the research on weight loss? I want to take a step back and show you this slide, not because I expect you to read every tiny letter on there, but this slide is really highlighting the complexity of weight. On the left, we have factors inside the person that are contributing to how their body stores energy, and on the right are factors outside of the person. And this spans environmental factors, social factors, cultural factors, psychological factors, biological, genetic. There are all these different things that dictate our weight. And we actually still don't even fully understand weight. This is a very active area of research. So for example, something that I was really interested to learn recently is that there are 8 viruses that have been shown to cause obesity in animals, and in humans, adenoviruses have been associated with obesity, with AD36 being the most well-studied. So they looked at 502 participants from a variety of cities across the US and found that about 30% of obese participants and only about 11% of non-obese had antibodies to Ad36, indicating that they had had this virus at some point in their lifetime. And when they compared kind of the two groups, people who had had the virus at some point in their life and people who had not, they found that the group who had was, on average, 9 BMI units heavier than the antibody-negative group. They also looked at twin pairs, right? Let's get down to the genetics of this. So in 28 twin pairs, where one twin had been infected at some point in their life and the other twin had not, the antibody-positive twins had a higher BMI and body fat than the uninfected co-twin. So this is just one example of how we are still trying to understand weight, and we really do a disservice to ourselves and to our patients when we perpetuate the kind of calories in, calories out, very oversimplified model of weight. So weight is complicated and weight loss is even more complicated. Most people are able to lose some weight, right? Like if you start exercising more and you eat less, sure, you're probably going to lose some weight. However, most people are not able to keep off that weight in the long term. But that's not really the message that we get in the media or even in the academic literature. And here's an example of that. So I was reading this article that said 3 randomized controlled trials have provided strong evidence that Weight Watchers is an effective weight loss program. Awesome, right? Like Weight Watchers is super ubiquitous. Let's refer all of our patients to Weight Watchers. But I looked up what were these 3 randomized controlled trials. And what I found in those articles was that on average, people lose about 10 pounds in their first year of Weight Watchers. And if you follow them over 2 years, they start kind of regaining some of that weight. So the typical weight loss trajectory looks something like this. People lose, they might drop some weight initially, and then over time, they gradually regain. And this is one reason I really advocate that weight loss studies that are only following people over a year are just not even very helpful for us to understand whether it's effective or not, because we really need that long-term data to understand, is this weight loss going to stick? This was a research study, an 8-year intervention with people it was an intensive lifestyle intervention for weight loss for people with diabetes versus just randomizing people to a diabetes support and education group. So they had over 5,000 overweight and obese adults with type 2 diabetes, and they really wanted to look at the impact of this weight loss program. And it was a fairly diverse sample. So the intensive lifestyle intervention was really focused on reducing calories, especially calories from fat. So they were providing a lot of information on nutrition and increasing the frequency of exercise, although they did not have like a very specific exercise program that they asked people to follow. And one thing I really want to highlight here is that this was not like a study where they did an intervention and then followed people and did assessments for 8 years. They were intervening with these people for 8 years. They were in this weight loss program for 8 years. And these were the results. So you can see that people in the intensive lifestyle intervention had an initial big drop in weight and then gradually started regaining to the point where at year 8, overall on average, they lost a little under 5% of their body weight, as compared to people in the diabetes support and education group who lost on average 2% of their body weight. So the average male in the intensive lifestyle condition started the study at 240 pounds and ended at about 229 pounds. The average female started about 209 pounds, ended at about 199 pounds. If you told a patient, I'm going to refer you to this really intensive program, and after 8 years, you will have lost 10 pounds. Like, how excited do you think that your patient would be about that? And this is like our best effort. Like, this is like, we are following these people, we are with them. They had, physicians, psychologists, dietitians, like exercise specialists. They had everybody involved in this. And this is the best that we kind of have in terms of how we can help people lose weight. And you can imagine that most people, when they're making an effort to lose weight, are not getting as intensive an intervention as this. One thing also to note is that about a quarter of the people in this intensive lifestyle intervention actually ended up gaining weight by year 8. So overall, we find that long-term follow-up studies document that the majority of individuals regain virtually all of the weight that was lost during treatment regardless of whether they maintain their diet and exercise program. So I just want to take a pause here for a minute and have you, again, imagine patients that you have worked with who are overweight or obese and their experiences with weight loss. And you may have had some patients who had some success, and you may be able to think of patients who lost some and then gained and then lost and then gained. And that's a really common pattern that we see. So just kind of imagine from their perspective how frustrating that experience might be. So common outcomes, when we tell patients, I want you to lose some weight, common outcomes are something like this. I've been eating less and exercising more, but my weight hasn't changed. What's wrong with me? I'm doing everything right. Or I did lose some weight, and everybody was giving me compliments. My doctor complimented me, we celebrated together. But now I'm slowly gaining it back, and the compliments have stopped. Again, what's wrong with me? And this can really ultimately lead to shame for people, that they are putting in their best effort, but it's just not working, and so they must be doing something wrong. And we know that when people feel shame, when they feel stigmatized based on their body weight, it leads them to want to eat more and exercise less because shame is not a motivating factor for health. So this is why I'm arguing that sometimes when we recommend weight loss for patients, it actually ends up being harmful for them. So what do we do with this? As providers, as people who really want the best for our patients, what do we do? My first recommendation would be to get more education in this area, and I will highlight that there is this continuing education credit available at ruddcentercme.org. In general, the Rudd Center has some really fabulous resources on weight stigma and understanding this topic. And this continuing education, is really targeted at people working in healthcare. And the other thing is just to be open and willing to confront our own bias. This is something I still have to do every day because we are bombarded with messages from the media and our culture that being thin is good and being fat or overweight is bad. And so it's something that we have to challenge for ourselves and for our patients. My next recommendation would be to really ask your patients about their health behaviors and not assume based on the way that they look. So what might that sound like? I like to check in with all of my patients about their everyday eating and exercise patterns, since we know that good nutrition and frequent exercise have a huge impact on our health. What are your thoughts on your current exercise and eating patterns? Or for some patients, I noticed that, say your A1C has gotten higher since our last visit. What are your thoughts on why this might be happening? So really opening up the conversation for them to jump in and showing them that you're not making assumptions about what's going on. Another really important thing to keep in mind is that when patients want to lose weight because it was recommended by their provider or not, they often are turning to really unhelpful or even harmful strategies to lose weight. So as providers, it's very important for us to assess for disordered eating among patients who are saying that they're struggling with their weight. So we want to avoid praising things in somebody who's overweight that we would worry about or diagnose in a thin patient. So even if you have a patient come in and they have lost some weight, and it is exciting, making sure to ask them, what are you doing to lose this weight? And if they tell you, well, I just stopped eating during the daytime, I just have one meal at night. That's not something that we want to reinforce. So in fact, we actually in that situation might want to provide some education on how fasting can lead to overeating and how they're really setting themselves up for failure. So these are some examples of how to assess for disordered eating. How often are you eating meals and snacks? Do you ever have a sense of loss of control when you're eating? Like you want to stop or you know that you should stop, but you can't stop yourself in the moment. What is the largest amount of food that you've eaten during one of these episodes? And these questions are really getting at binge eating disorder, which I want to mention for a moment because binge eating disorder was added in DSM-5 as a full clinical eating disorder. And although it's not common in general, about 5% of people in their lifetime will have binge eating disorder, among patients who are seeking weight loss treatment, as high as 30% of those patients might have binge eating disorder. And binge eating disorder, unlike the other eating disorders, is relatively similarly common in males and females. And that's true for veterans as well. Another question to get at binge eating might be, do you ever eat in secret or feel very upset about how much you've eaten? And then, this one's kind of getting more at bulimia. Do you ever do something to try to make up for how much you've eaten, like exercise a lot, fast, take diet pills, or throw up? Eating disorders are frequently stereotyped as something that only affects people in thin or normal weight bodies, and that's just not true. We certainly might have overweight or obese patients who have bulimia. So the next recommendation would be to really talk with your patients about health behaviors rather than their BMI or losing a certain amount of weight. So things like nutrition, portion size, how often they're eating meals and snacks, how to eat mindfully, and exercise. These are all good targets. And I know that as providers, we don't always have time to cover all of these things in a visit. So really making sure that you take advantage of the other resources, the people who do have time. So making referrals to nutrition, therapists, or other professionals who practice from this movement that's called the health at every size movement. The belief that, no matter what size a patient is, that we can help them live a healthy life, and they can be healthy no matter what their size is. So some examples of how you might talk about these behaviors. People often find it helpful to track healthy behaviors. Would you be open to tracking how often you're exercising and then bring that to discuss in our next visit? That might be a really nice alternative to talking about weight in the visit. Or, I have a colleague down the hall who specializes in nutrition. Would it be okay if I have him call you? I have a colleague down the hall who specializes in helping patients reach their health goals. Shout out to behavioral health. Would it be okay if I introduce you? And ultimately, we want to shift the focus away from weight to these behaviors. And our patients might come in and they might be very focused on weight loss, right? Because that's the message that they're getting from our culture as well. So we need to provide the education for them. Weight is one indicator of health, but I'm wondering if we can shift our focus to your everyday health behaviors instead of the number on the scale. Or saying something like, you're frustrated by your attempts to lose weight. It might be helpful to know that improving nutrition and exercise habits has a big impact on our health, even if we don't lose weight. Another strategy, eating healthier and exercising more, it actually doesn't always result in weight loss. I'm really excited to hear about the hiking that you've been doing, and I can tell that you're taking your health seriously. So making sure that even if the patient hasn't lost weight, that we're really asking about behavior changes that they have made and reinforcing those and really sending the message, that's okay. Even if you didn't lose weight, this is awesome for your health. Another practical thing to consider is how you might want to directly talk about weight stigma with a patient, particularly if you are prescribing a medication that might lead to weight gain, so psychiatric medications, for example. Patients might have a lot of thoughts about that, and just being willing to validate that, yeah, it's really hard to be an overweight person in this culture, and that just might be enough to make patients feel more heard and understood. You might also have a direct conversation with your patient about weight stigma that they may have experienced in the healthcare system. So if you have a patient maybe who hasn't been coming to appointments and is overweight or obese, you might ask them. Sometimes people avoid the doctor's office for fear of being judged. I'm curious what it's like for you when you come to see me. Or, I appreciate your openness about your struggle with your weight and health behaviors. I'm wondering if you've ever felt judged or shamed for your weight when you come here. Really saying, I'm here to support you. I don't want you to feel that when you're in this office. We also want to make sure that patients have realistic information about their weight loss efforts. So they might be very adamant that they want to lose weight, and it might be for health reasons, and it just might be for appearance reasons. So obviously my first recommendation would be to try to provide the education that might shift them in a different direction. But you also want to let them know that, okay, so you're going to start doing Weight Watchers. I want you to know that on average, after 2 years of people doing Weight Watchers, they lose about 6 pounds. How does that sound to you? So letting them know straightforward, or oftentimes people lose weight and then they gain it and then they lose weight and then they gain it. I really want to avoid setting you up for that pattern. So let's talk about making long-term behavior changes. And really helping set them up well to do that. So giving them those referrals. keeping in mind that patients do not necessarily know what these long-term healthy behaviors are. This is very a cultural issue. They might not have grown up with that information. And we're also constantly given misinformation and being sold these fad diets. So it makes sense that they would turn to these things when they're trying to lose weight. Also reinforcing behavior changes even if they don't result in weight loss. This is one thing that we've seen this year being involved in the MOVE program. You know, a lot of patients come there, they're there because they want to lose weight. But by the end of the program, we often hear from veterans that, you know, they're excited about other changes that have happened, that they're able to walk up the stairs and not get winded, that they're, you know, stretching further, or just these kinds of changes in their life, whether or not they've lost a significant amount of weight. So really helping patients look at these other indicators of their health. And the last thing that I want to emphasize is that we all need to be really critical consumers of the research that's out there on weight loss. So remembering that if you see a study that sounds really exciting and promising, asking yourself, okay, did they follow patients for more than a year? And ideally for 3 to 5 years or more. Is the weight loss that they reported clinically meaningful? You know, patients might have lost a statistically significant amount of weight, but is it really going to be something that's going to be helpful for their health? Did the study just look at and report changes in diet and exercise behaviors? Oh, sorry, did they look at and report changes in diet and exercise behaviors or not? Did they just focus on weight and not kind of acknowledge the fact that it could have been those behavior changes, that improvement in cardiorespiratory health and fitness that might have led to these positive outcomes? Did they confuse correlation with causation? And did they examine whether, again, these behavior changes alone might account for the changes in health outcomes? So just to summarize, back to my take-home points. Weight stigma, very important thing that impacts a lot of our healthcare interactions, and that we want to be talking to patients about their health behaviors rather than just the number on the scale. Here's some additional resources if you are curious to get more information. Like I mentioned, the Rudd Center is a great one. The Binge Eating Disorders Association has some great information. And the Academy for Eating Disorders has specific guidelines on obesity and obesity prevention. And thank you very much.